I'll just wait for a few minutes for everyone to come back. I'll be just waiting another few minutes for. Okay, so coming back to the post-operative course of our babies, the first baby after operation, he required HFOV because he was not hemodynamically unstable. He was pulmonary pressures were increasing. He was going into shock. He required milrinone, sildenafil, and bosentan for pulmonary hypertension. By shock and dysfunction, he was started on inotropes and vasopressin. He was on invasive ventilation for 10 days. The second baby again post-operatively had issues of pulmonary hypertension, which was a continuation. He was on milrinone, sildenafil, and bosentan. There was shock and ventricular dysfunction for which he required inotropes and vasopressors. He also had a very large PDA, which was 6 to 7 mm, which was closed. Because of that, he had a post-cardiac ligation syndrome for which he was started on inotropes and hydrocortisone. He was extubated 4 days after surgery and he was on non-invasive ventilation for further 10 days. The third baby was intubated and for 2 days, he was taken on NIV on third day and he was taken to room by fourth day. This baby with no pulmonary hypertension did not require any vasodilator support or any inotropic support. Coming to long-term CDH pulmonary hypertension follow-up. So follow-up can be done using echocardiographic measurements of pulmonary hypertension. Only a minority, that is less than 10% of CDH PH patients have persistent PH at 6 and 12 months of age. These patients are patients which require longer duration of mechanical ventilation, longer hospital stay, had persistent pulmonary hypertension, required pulmonary vasodilators. They also and had a pulmonary vasodilator for a longer time. So coming to our 3 babies, what happened to our 3 babies? The first baby died on 10 day of life 14, 10 days post-operatively. He had a pulmonary hypertension which was resistant to vasodilators. He had shock and ventricular dysfunction, and he finally went into catecholamine-resistant shock. He had multiple organ dysfunction syndrome, and we could not resuscitate the baby. The second baby was discharged on 30th day of life after complete recovery. He was on invasive ventilation for almost 10 days. Then he was on non-invasive ventilation for almost 10 days. After that, we were following up. As his pulmonary hypertension resolved, we started tapering. We stopped bosentan, but we continued with oral sildenafil because his pulmonary pressures were still above 35 to 40. He was on regular follow-up for monthly basis. This baby is growing well, developmentally normal, and still continue with oral sildenafil because his pulmonary pressures are still about 35 to 40. The third baby, we discharged on day of life 11 after complete recovery. He did not require any pulmonary vasodilators. This baby is growing well and developmentally normal. Some future therapies are being investigated for CDH-PH, although they are still in the investigative therapies. They are done in rat models and they are not done in any children or pediatric population or adult population. These future therapies include Celaxipab, which is an oral prostacyclin agonist, Macitentan, which is an endothelin receptor antagonist. It has action similar to bosentan. Riociguat, which is a soluble guanoside cyclase stimulator, which restores the nitric oxide CGMP pathway. There are stem cell therapies and progenital cell therapies which are being investigated. Antenatally, anti-inflammatory therapies, anti-proliferative strategies like tyrosine kinase inhibitors, PPR gamma inhibitors are being used, but these are still in the nascent stages and it will take a lot of time for them to be proven in any way. Coming to the take-home message, finally, CDH-PH plays a central role in the overreaching pathophysiology of CDH. A handful of treatment strategies and algorithms have been applied to infants with CDH-PH, but they all still remain understudied. Given that CDH-PH is a multifactorial, multisystemic entity, a combination of basic, translational, and clinical science is needed to change the management paradigm of this disease. And as we spoke about echocardiograph diagnosis, echocardiographic assessment as the disease progresses, and echographic management as the disease progresses is important. Now we'll open the session for any Q&A. You can unmute yourself and ask for question and answers if you have any doubt. So there were two questions which were already asked, and sir has answered them. The first, what is your first line drug for CDH-PH? We usually use sildenafil, and if there is any dysfunction, we go for milrinone. Criteria for starting sildenafil is again clinical parameters and based on echocardiograph parameters of pulmonary pressures.
Why not INO can be considered as first line drug instead of sildenafil?
Again, as I spoke about, INO, first of all, it is not present in every settings, and efficacy is still not proven. Although it is said that within the CDH consortium guidelines says that INO has to be used as a first line drug, but as INO is not present in every places and it is not even feasible, and INO is contraindicated in cases of ventricular dysfunction. So if there is a case of ventricular dysfunction and if you start INO, this will again lead to pulmonary venous hypertension, which will again lead to deterioration of the baby. So
no, if not, if there is no ventricular dysfunction and INO is available, should it be considered as first line drug?
If there is no dysfunction, if there is only purely pulmonary pressures, and if there is an oxygenation index higher than 15, if there is severe PPHN, OI of more than 15, if this pre and postnatal diastolics are more than 10%, then you can go for INO. But if his pulmonary pressures are in the range of mild to moderate and there is no severe PPHN, then it is better to start with sildenafil rather than directly go to INO.
Can I interrupt?
Yes, sir.
I think it's one of the important things for all of us to understand the importance of sildenafil in our Indian settings, importance of the cost effectiveness outcome of the sildenafil, and think about the proven aspect about if you use the sildenafil appropriately along with your lung recruitment and gentle ventilation, then most of the time you will be actually not requiring the nitric oxide. Yes, I do agree what Aditya has mentioned that sildenafil, a lot of people when available, sometimes it has early intervention and people try to use early to have a better result. But think that you don't have sildenafil in your unit, and then think about good management aspect. Most of the time, you're going to win the battle. Even though we have a sildenafil, nitric oxide available in the unit, we are actually not requiring that role of nitric as we thought 10 years before or 20 years before, because that time the situations were different. So I would say that even for routine pulmonary hypertension, if you appropriately manage your lung recruitment, one only thing which is contraindicated, not proven or not good is surfactant therapy. But in the other cases of pulmonary hypertension, if you recruit the lung with a proper surfactant therapy, you are going to win the battle a lot of time. And very less number of the patient you will require the nitric oxide. Yes, we all know nitric is the best drug. We all know nitric has a fantastic vasodilatory effect. But before that, think about proper recruitment of lung and think about proper ventricular function. Yeah, Aditya, back to you.
When do you consider prostacyclins? Prostacyclins usually we take it as like the third line drug. First we start with sildenafil. Then if there is a increasing pulmonary pressures and some kind of dysfunction, then we try to go for IV milrinone. And despite this, if you want the patent ductal status to open so that it acts as a pop-off valve mechanism, then we go for prostacyclins because it helps in decreasing right ventricular systolic pressure, and also it helps in keeping the PD open, which will decrease the right ventricular systolic load.
Fine. I think most of the points covered by Aditya. Any more thought process, any more suggestions? Always welcome. But I think we are planning to cover this pulmonary hypertension series over the course of the time. But try to understand that the clinical evaluation, pathophysiological assessment, and echo documentation is very important when we are going through the pulmonary hypertension of diaphragmatic hernia. Good thing is happening now. Antenatal diagnosis, good delivery room services, and availability of early interventions in the NICU has reduced the mortality related to diaphragmatic hernia. Isolated diaphragmatic hernia, now good results reaching up to 70 to 80%. You just have to manage properly the pulmonary hypertension if it is there. But the diaphragmatic hernia, with most of the pulmonary hypertension, they have a good response with the proper recruitment and the proper management. So I think with these points, Aditya, you can think about most of the points Aditya has covered. It's not easy to cover, Aditya, in only 20 minutes about echo parameters. It has a separate 5 or 6 lectures what he has covered into that 20 minutes about pulmonary pressure assessment. One is the right ventricular systolic pressure assessment. Second, he has done the assessment of the pulmonary vascular resistance. He has done the assessment of ventricular septum. He has done the assessment in the form of additional RV function, LV function, cardiac outputs, MPI, a lot of things he has covered, but I think those are the basic parameters what you all need to document and go from that aspect. So I think it's time to say good night. Aditya, any more points from your side?
No, sir.
Okay, so I think time to say good night. Thank you, everyone. See you on the next series. We will discuss about the basically hemodynamics of pulmonary hypertension. We can think on that one. So let's see that. Thank you. Good night, everyone.
Thank you, sir. Thank you, everyone, for attending.